Well, thyroid surgery is very broad. So we do have a very big spectrum of different indications to do thyroid surgery. Obviously, the most obvious one is thyroid cancer. Thyroid cancer is primarily treated with surgery, and surgery is actually the mainstay of the treatment. The second kind of main group is big goiters. So basically, all those patients who developed non-toxic goiters, who are going to get who are going to have problems with pressure symptoms, either at the level of the neck, or if those goiters go into the intrathoracic or the back of the collarbone, these patients are going to have problems breathing, and therefore that's another main indication. The other group of indications is Graves' disease. So basically, all those patients who do have an overactive thyroid problem, and these patients, although this condition can be treated with non-surgical means, either with medication or iodine treatment, then surgery offers them a complete final solution to their problem, which is also really very important. And then we do have a number of other situations in which the thyroid surgery is necessary. For instance, if you have a nodule by which the fine needle aspiration cytology, i.e. biopsy that you've taken from the sample, is not conclusive or maybe suspicious, then in those patients you will require to have thyroid surgery. And then, of course, there is other really the combination of the above, in which patients, they may have a very very large goiters with malignant change, or they may have very large goiters with an overactive thyroid. So the combination of the above would also means that these patients will require surgery. Well, the scale or the de-escalation of thyroid surgery has actually been very prominent in other disciplines. For instance, in breast or lung, there's been also a significant de-escalation as to how we do the procedure. So in a way, we take less with the same benefit. And in thyroid surgery, it's a little bit like that. When I started, doing thyroid surgery as a consultant 22 years ago, basically for thyroid cancer, for instance, we used to only do a total thyroidectomy. For big goiters, we only did a total thyroidectomy too. So although there's a specific indication for that, then there's been some de-escalation. So it's not necessary to remove the whole of the thyroid gland. But for the purpose of the question, so in advanced stage thyroid cancers, it will be necessary to do a total thyroidectomy. In goiters in which there is a bilateral compression, these patients will require a total thyroidectomy. And in patients who have got Graves' disease, an overactive thyroid, then those patients will require as well total thyroidectomy. The rest, you can actually find that maybe an hemithyroidectomy, either removal partly of the thyroid gland, one lobe, may be completely necessary. Even in early stage cancer, that is a perfectly very good solution. Well, how do you, in a way, kind of value or success? Of course, if you do have somebody with thyroid cancer and then you treat it, that's going to be a really 100% success. I would say that in the great majority of patients, just put everything in one hole. You will basically find that you will be completely successful with your thyroid surgery in about 90% of patients. So we divided those groups. So in thyroid cancer, you always potentially have a kind of around about 90% local control rate, and that's through all the spectrum of the cancers. In multinodular goiters, where there's a lot of compression symptoms, you may start with a lobectomy, or either removing part of the thyroid gland, and then if we do a total thyroidectomy, that will be basically means that the patient will be completely cured. And in the same with Graves' disease, but the surgery it needs to be very accurate, very precise, and therefore that will obviously be impacting on the success rate. But by and large, in all the kind of surgical indication groups, you will really have a very good success rate after doing thyroid surgery, especially if your indication is the right one. Yeah, well, thyroid surgery would not be as it is. It would not in a way have the same kind of risk and high stakes without the complications that they got. And the reason being is that the complications will be directly impacting in the voice box in the larynx. So when we do consent the patients for thyroid surgery, we will need to warn them about the following. First of all, obviously the indication of the surgery, its rationale, why we're doing the surgery, and then the risks. And of course, the majority of thyroid surgery is done on the general anesthetic, so there may be a risk with the general anesthetic. There is a small risk of infection, which is around about 1%. There is a small risk of bleeding, either intraoperatively or postoperatively, which is actually around about 1%. And that's actually something very important, because if that bleeding occurs after the surgery, then you will need to kind of establish some measures in order to release immediately that bleeding. The main, more specific complications of thyroid surgery are mainly the injury to the recurrent laryngeal nerves. These are the nerve that supplies the voice box. They run behind the thyroid gland and they go into the voice box. And so it is very, very important that you don't injure those nerves. Of course, if you do a unilateral operation, i.e. only one side, and you damage one nerve, the patient may become hoarse, and that could potentially recover if it's just a transient palsy. But if you do damage both nerves doing a total thyroidectomy, then the patient may end up with an airway obstruction and they may require tracheostomy. So that's actually a very, very, very problematic issue. The other group of complications, it will include the parathyroid glands. The parathyroid glands are very important small glands. They are the size of lentils. They are behind the thyroid gland. And what we do at the time of the surgery is to peel them over, make sure they do preserve them with the blood supply. If the patient loses the one gland or two, may not be a problem, but if he loses all four of them, then the calcium level may drop, and that can be a really big problem as well, because that calcium needs to be replaced. So it is an important really thing that you need to discuss with the patients. And the final one is not necessarily a complication, but it's actually sequelae. So if you do remove the thyroid gland, obviously those patients will need to take thyroxine for life because there's no other, they will not be able to fabricate the thyroid hormone. So this is actually something we cannot really do control. Of course, if you do only half of the thyroid gland, that's not a problem, or may not be a problem. But if you do remove the do a total thyroidectomy, then those patients will require to have a thyroxine for life. Not necessarily. This is a very common question. People are actually very conscious, and they heard about that. But really, if you are the thyroxine is actually well controlled, and your TSH, which is the thyroid stimulating hormone, is not kind of not raised, and that's actually because patient is fabricating enough level of hormone, or they are properly replaced, that should not be a problem. What is actually imperative to avoid that is that the patients, they will require to have a thyroid function test checked every so often. What we normally do after thyroid surgery is when we see the patients in the clinic, usually 2 weeks after the surgery, we check those thyroid function tests. And then we do then adjust the thyroglobulin, the thyroxine. Normally, it is actually quite easy to calculate the amount of thyroxine that the patient needs, and that because it's actually 1.6 per kilogram of weight. So it's a very easy calculation to do. And of course, you need to include other parameters. So that monitoring in the first few weeks is actually very important. And then sometimes readjusting that level of thyroxine is also very important. Of course, there are many sedentary patients then in which maybe the requirement of thyroxine is less, but there are very active patients in which the thyroxine may be higher. So it very much depends on each individual patient metabolism, but it is actually very important that you do check them. If however, you do get very good control of your thyroxine, your TSH, the likelihood of gaining weight is very, very, very small.